Hi, I'm Jeff Hoyt, Editor-in-Chief of SeniorLiving.Org. Today I'm speaking with Audiologist Brad Ingrao. Wait, you don't know what an audiologist is? That's exactly what we're going to discuss. Brad is going to tell us what he's been doing as an audiologist for decades, how the field of study began, and what to expect the first time you meet one to get your hearing evaluated. Due to social distancing, we will be conducting the interview online on Zoom. Hi, it's Jeff Hoyt, Editor-in-Chief of SeniorLiving.Org. Today I have the pleasure of talking to Brad Ingrao, who is an audiologist. He's worked in clinical settings, academic settings, and in industry positions. And today we're going to talk about what exactly is an audiologist. So welcome, Brad. Appreciate you taking the time.
Hi, Jeff. Nice to be here again. I'm always happy to help people understand what the heck I do, because anytime you have ologist at the end of your name, it's somewhat confusing. And because I work with people with hearing loss, I have been accused of being a proctologist more than once. So people mishear me. But an audiologist is what I like to call a non-medical doctor at this point. Our entry point is a clinical doctorate. You can kind of think of us like an optometrist or a chiropractor for your hearing and balance system. So we're not going to do surgery. We're not going to prescribe medicine, but we're going to work in conjunction with the medical part of your team to identify parts of your hearing and balance system that may not be operating as well as they used to. We have a whole series of tests that we do. Some of them are actually quite old, going all the way back to the 1930s. And in fact, audiology as a profession kind of grew out of World War II. So after World War II, a bunch of guys came back and they had blasted ears because they were in B-1 bombers for the first time and that kind of stuff. And so the Walter Reed Hospital really developed the first comprehensive auditory rehabilitation program. And I was very fortunate to have a mentor, Mark Ross, who's just an amazing guy. He went through that program and was so impressed with it. It was 6 weeks. It was your full-time job in the Army to go and get to learn how to hear again with your hearing aids. He was so impressed with that. He went to Stanford University, got a PhD, and became the first audiologist with a significant hearing loss way back then. So I was very kind of drawn to that field from my personal experience of my uncle, who as a musician started his career, was doing great, and then lost it all very quickly to a mastoid infection. Ended up selling hearing aids in my dad's pharmacy. So I've been around it for a while, and I wanted to kind of explore a little bit more of the medical rehabilitative component of it. So early on, audiology was, you'd come to us, we would test your hearing, we would actually evaluate several different hearing aids on you in a sound booth and pick the right one, and then write your prescription. You'd go down to see my uncle, the hearing aid specialist, and he'd sell you a hearing aid. Then you'd come back to us and we would evaluate the effectiveness of that hearing. So we do some of those tests again. Over the years, it's sort of evolved, and now audiologists are also involved in the direct dispensing of hearing. We also look at not just can you hear the beep and push the button when you hear the beep, but we look at how accurately your hearing works. So if I give you a list of 50 words, at a level that I know you can hear, what percentage of those do you get correct? And that can sort of help us differentiate those early hearing losses where it's mostly a volume problem. And they do fantastic with hearing aids. And then what about those people who have more severe hearing loss? And no matter how many times I say, what's that big loud noise, you hear what's that big outdoors. And if I yell it louder, it's still going to be wrong. So those kinds of differentiations are a little bit different between an audiologist and somebody else who may evaluate your hearing. But then we also look a little deeper. We can look at how well do you hear speech when there's also background noise, and what kind of background noise makes you tank faster. So we have some tests where it's like you're at a cocktail party, and the cocktail party sounds 10 feet away, and you hear a sentence. And then the next sentence, the cocktail party gets a little closer and a little closer. And we track how much background noise you can actually tolerate before your ability to function really degrades. We look at the internal structures of the ear through a couple of tests that are non-invasive, but it allows us to determine, is it an outer inner ear part or an inner ear part that's falling apart? And we also look at balance. Balance is sort of a newer thing for us to look at, but when we look at balance, we're looking at, is the inner ear affected? Is the mechanical structures of those inner ears, or is it a central processing problem? Some people have issues, they've had concussions, they've got MS, those kinds of things, and that can affect balance. And we can help the medical team, again, differentiate, is this something where I need to treat this medically, or do I need to treat this rehabilitatively? So that balance component of our scope of practice works usually very much hand in hand with physical therapy, occupational therapy, that sort of thing. And oftentimes we'll work with overall rehab departments, that sort of thing. The last thing that we kind of look at in terms of an evaluation is there's a lot of people out there who hear perfectly well for the volume of sound. And in a quiet environment, they hear perfectly accurately. But there's something between their ear and their brain where things kind of fall apart. We call it auditory processing disorders. And we have some ways that we can look at that, both through some functional tests by giving you speech that's either mixed in with background noise, or sometimes we stretch it out or speed it up really fast, and that will tax different parts of the auditory system. We can also do some what are called electrophysiologic tests. So you think about an EKG or an EEG. An EKG for your hearing system would be brainwave activity at different parts of the auditory system. And depending on what task we ask your brain to do, we expect to see certain kinds of waveforms. And if there's a disturbance in those waveforms, again, that will say, all right, this is either an organic problem, you had a stroke, or you had a head injury, or this is a developmental problem, and this is something that may recover with rehab. And again, we use that information to help guide the medical and rehabilitative parts of our team. I've worked in a lot of big hospitals, VA hospitals, large community hospitals, and I really appreciate that multidisciplinary approach. I've also worked in private practice where it's all just me. I really like that multidisciplinary part of audiologist, because now I can say, okay, here's the roadmap, and then I can hand that off to the individual tour guides who are going to take that patient through the journey and help them rehabilitate those parts, because I can't do everything, and they're much better at that rehab part than I am. So that's kind of what we do. We do still do some rehab, and on the far extreme of hearing loss, we also work with something called cochlear implants, which after hearing aids no longer help. That's a piece of it. We work with people as young as literally 3 or 4 hours old, all the way up to 100 and whatever years old. I think the earliest hearing screening I ever did was 5 hours old on a little baby, and that's that electrophysiologic stuff, so the baby doesn't have to respond. We just measure what their brain's doing. And I think my oldest hearing aid patient was 103, and he was trying to talk me into a longer warranty on a hearing aid than 3 years. So I made him a deal, and he beat me out of a warranty. So I think that's pretty much covers what I do and what I've been doing for almost 30 years. Very rewarding work, very nice to see that person who started out saying, can you say that again, doc? Can you say that again? And they come in with their hearing aids 3 weeks later and go, yeah, things are going pretty good. I'm hearing pretty good. So that body language is often the key that I'm doing a good job.
Thanks, Brad.
All right. Appreciate it. Thanks very much.
Bye-bye.